Yeah. So good evening, everyone, and I hope that everyone is keeping safe and taking good care of your health. We are also, and I also hope that all the attendees who've been attending the series of up-to-date webinars that we've been having every month, you're finding it useful and it's adding to your knowledge of uveitis. On behalf of Uveitis Society of India, I think we would be very happy to get a feedback from all the members who've been attending these series for last few months. I would now request Dr. Vishali Gupta, President of the USI, to start and introduce this session.
Okay, I think we still have 1 or 2 minutes to 5 o'clock. So let's wait for others, but I will take this opportunity to introduce 4 young speakers and panelists for this session. So Pia Giorgio is already smiling.
I'm a former young, that's why.
You're young.
I used to be.
No, you still are young. So this is going to be a very interesting session on OCT and OCT angiography. And when you hear Alex and Pier Giorgio, you will know what I mean by interesting. You'll be totally bowled over by their talks because they are not the usual talks telling you the usual stuff. They will exactly tell you how to pinpoint a pathology, how to differentiate infective from non-infective uveitis, just looking at the OCTs, looking at the OCT angios, and what are the different possibilities that you can do. It's an amazing talk. Both of them, I have listened it quite a few times, and it's really a treat to listen to both of them. And Pier Giorgio is, both of them are Italian, and you know how good Italians are in imaging. And of course, we have Padma Malini and Anirudh joining us for panel, and you all know them well. So I don't think I need to introduce formally any one of them. Right now, Pier Giorgio is in Cleveland, Abu Dhabi, and Alessandro is in Milan. So you just have to listen to their talks, and I don't think I personally have to say anything. So with this, I will pass on the thing to Manisha to start forward the proceedings.
So as Dr. Vishali rightly mentioned, that they don't really owe any kind of an introduction, but I have to do this for the benefit of the audience. So our first speaker is Dr. Alessandro, and he's an associate professor in the Department of Biomedical and Clinical Sciences in the University of Milan. He's known for his research in infectious diseases, ophthalmology, and clinical immunology, and he has an expertise on OCT. He would be speaking to all of us on the role of OCT in uveitis. So over to Dr. Alessandro.
Thank you. Thank you for this kind invitation. Can you see the slides?
Yes.
Okay, so I will start my talk. It's an honor and a pleasure to speak to you. So I won't waste any more time, and I will start with the talk. These are my disclosures. So we're going to talk about OCT in uveitis, and I guess all of us use OCT to detect macular edema and uveitic macular edema to monitor it over time. And this is probably the first kind of application that all of us use for OCT in uveitis. But there is a lot more that we can get from this kind of technology. And we can realize easily this when we look at the literature. If we look into PubMed and we check the number of publications over time, we see that in the last 10 years, they have almost doubled. And these are just publications that you can find if you type OCT and uveitis in PubMed, but I'm sure there are way more than this. So what's new? Why OCT is so used? And the reason is that you can get, as I said, way more than just monitoring edema. You can grade inflammation, you can use it for differential diagnosis, you can check the prognosis and the management of the patient, and of course you can monitor the follow-up and the response to treatment. And we will go through all these 4 points in this talk. So let's speak about grading inflammation. We all use the standardization of uveitis nomenclature scales, so the SUN scales, to grade inflammation in the anterior chamber and in the back of the eye. However, we know that these scales have some limitations, and you all know that they are non-continuous, they are quite subjective, and there is low agreement between graders. So they remain the current paradigm in uveitis, both in clinical trials and routine clinical practice, but somehow we need to overcome these limits. And so we need to increase the inter-observer agreement both for treating the patients on our daily practice and to get more reliable results in clinical trials. And OCT can help in this. This is the first, probably the first report in 2015 showing that OCT in the anterior chamber can actually visualize the cells floating, and there is a good agreement between the number of cells that you can actually count on OCT scans and those that you can see at the slit lamp, or the grades that you can see at the slit lamp. More recently, this publication aimed to see whether you could actually count the cells and not only grade the cells, but also the flare in the anterior chamber with anterior segment OCT. So you can count the cells, we already said this, and these are the results. So you see that the number of cells in uveitic eyes with active inflammation are way higher than those in inactive uveitis and controls. And you can see that there is a very good agreement between the OCT cells and the clinical grade. And what about flare? Flare is a bit more tricky. So flare is a sort of, we all know that is induced by proteins floating in the anterior chamber. So the higher the number of proteins floating in the chamber, the higher the interference the OCT signal gets. And so the higher the brightness inside the anterior chamber. Now you need to average the brightness that you get into the chamber with something which is unaffected by the structure of the eye, such as the corneal thickness and other features that can disturb the signal. So if you get this ratio between the brightness outside the eye and the brightness inside the anterior chamber, you get this index that we named aqueous to air relative index, and this reflects the number of proteins floating in the anterior chamber. And once again, you can see that this index is higher in active uveitis compared to inactive uveitis and controls, and that this reflects exactly what you can measure with the laser flare meter. So somehow, OCT gives you the possibility to assess the inflammation in the anterior chamber in a way which is more objective and repeatable compared to the standard grading system. And with more advanced technology like this one, this is swept source anterior segment OCT, you can move even beyond the limit of the anterior chamber, and you can see the anterior vitreous and some features of the lens. What about the vitreous? We just named it. So we know that with the posterior segment OCTs, we can see the vitreous pretty well. So why don't we use the OCT to grade the vitreitis? And this is something that was published in 2014 by the group of Piers Keane and Alastair Dennison. And what they did was to basically check the back of the scans of the back of the eye of eyes with uveitis. And they found that the quality of the image was decreasing as the vitreitis increased. It's a quite simple idea, but it's at the same time very new and very important. And what they did was to create a ratio once again between the brightness of the RPE, which is used as control, and the brightness of the vitreous. And they found, as you see here, a quite good agreement between the clinical grades of the vitreous A's and the brightness of the vitreous itself. So now we move to something which is more useful probably in our clinical practice, as what I talked so far is still in the research kind of stage. So can we use OCT for differential diagnosis? I'm showing you these 4 images because these are 4 lesions pictured in the eyes of 4 different patients. And to me, they look pretty similar to each other. So this is something that usually I show to my residents, and I ask them, what would you like to know about these lesions? And I guess what we all would like to know is the depth of the lesion first. And if we perform an OCT encompassing these lesions, we realize that we can get a lot of information, and we can kind of think to orientate our diagnosis towards one or the other etiology, just based on what we see on the OCT. I'm not saying we are going to diagnose a disease based on OCT, but we can definitely have a lot of clues. And this just because OCT allows us to understand which structures of the eye are actually involved in the inflammatory process. So if you look at the first one in the top left of the screen, you see that there is a lot of alteration occurring at the level of the retina, but there is sparing of the RPE and sparing of the choroid. Obviously, you have to scroll through the entire volume of the OCT. You cannot just stop at one single line, but in the interest of time, I could not show you the entire volume. So in this case, we are seeing a sort of retinitis, which is involving just the retina and sparing the other structures. And this is a patient with Behçet disease, which is known to spare the choroid and most of the time the RPE. If you look at the second one, you actually realize that the inflammatory process is on top of the retina along one vessel, is a sort of vitreous reaction, and is a patient with sarcoid. If you look at the bottom left, you see that there is a lot of inflammation going on, and we see that there is intraretinal changes. We have some retinal fluid, and we also have a thickening and a disruption of the choroid. Now, this must be a chorioretinitis, and in fact, what the patient is suffering from is toxo. So the choroidal involvement in this case suggests that the disease is not limited to the retina. And what about the last one? You see that the last one is somehow protruding from the RPE or from the choroid towards the retina through the RPE, breaking through the RPE. And in fact, it's a case of endogenous Candida endophthalmitis. And the pathogenous is actually growing from the choroid, aiming to get into the vitreous chamber. So OCT can suggest us or kind of point us towards the right direction. And what about if we could use OCT to actually diagnose different diseases that may look similar? If we think of the standard toxoplasmosis lesion, of course, you don't think of something like you see on the left, but we know that toxo in immunocompromised patients can actually resemble ARN. So the two diseases may look very similar. So if we compare, if you think about OCT, you have to think about histology as well. So the similarities between the scans and histology always suggest you something. And if you look at the histology of viral necrotizing retinitis, you see that only the retina is completely disrupted and the choroid is somehow spared. On the other hand, if you look at toxoplasmic choroidal, you see melting of the retina, so full thickness retinitis, but this is almost always made by choroidal granulomatous inflammation. And you see the similarity between the OCTs and the scans and the histology are quite impressive. So we did a study a couple of years ago, and we found that these choroidal involvement is definitely more present in patients with toxoplasmic choroidinitis rather than viral. So when you see this choroidal thickening and a disruption, you always have to think about toxo. There are also other signs, for example, at the level of the vitreous, you see these deposits, these oval-shaped deposits on top of the retina and along the posterior hyaloid. These are quite suggestive for toxo. You can also see these deposits in viral, especially VZV retinitis, but the prevalence of this sign is way high in toxoplasmic choroidinitis. So once again, if you see this sign, please think about toxo and then run your tests to confirm your suspect. And this is just an example to show you the usefulness of these signs on OCT. This is the case of a patient that was treated with the good systemic condition, that was treated with intravitreal injections of steroids because he had a VPT which was complicated by CME. And he had progressive worsening in his left eye and floaters, but no pain. And this was the picture of the left eye when we saw him first. And you see that there is all this retinal whitening, peripheral, which looks like ARN. So what we did, we just did a scan through one of the areas. And what we found was focal increased choroidal thickness, choroidal disruption, as you see on the left. And moving around, we also found this deposit on top of the retina. So these three signs were suggestive for toxoplasmic choroidinitis rather than ARN. And we decided to tap and inject Clinda and Foscarnet because we were not sure. But then the results of the PCR came back and they confirmed that toxo was positive. So we decided to treat him accordingly. And what we found was that after 2 weeks, he had a quite impressive improvement. So once again, you cannot base your decision only on OCT, but OCT can be really helpful in pointing you towards the right direction. And if you think about CMV retinitis, so viral retinitis, you may have different patterns of changes of the retina. And one particular pattern is these sort of cavernous lesions with the complete disruption of the outer retina. And this is just to show you another example of how OCT can help you in the differential diagnosis. I'll show you another case just in a second. This was a patient that came to a friend of mine, and at the beginning she was not sure about the kind of diagnosis here. So she did this OCT and she found these kind of alterations. So you see that once again, these resemble what I just showed you. So these sort of cavernous changes of the retina. And this is what a cotton wool looks like on OCT. So you see that there is a very quite an impressive difference. And in fact, the patient was suffering from CMV retinitis. So once again, an OCT can help you in confirming your suspicion. So if we move to another kind of disease, so like Candida, we know that from the clinical practice, and we know from histological studies and studies, preclinical studies, that Candida likes the vitreous cavity. And this is because these kind of fungi found the perfect environment to grow, the perfect concentration of sugar inside the vitreous, and they're quite protected from the immune system reaction inside the vitreous. So regardless where they come from, they try to get into the vitreous cavity. And they can come from the retinal circulation and they get into the vitreous straight from there, or they can come from the choroid. And once again, they try to aim for the vitreous. So they break through the RPE, they kind of erupt through the retina and they get into the vitreous cavity. And you see here the follow-up in 3 days time, how the lesion tends to grow towards the vitreous cavity. Now, what's interesting is other kind of fungi do not behave like this. So when you see this kind of sign at the on top of the retina, you always have to think about Candida. In fact, if you look at other kind of fungi like Aspergillus, they tend to grow underneath the retina in an horizontal spreading, while Candida goes from the back of the eye, so from the choroid, through the RPE, through the retina, into the vitreous. So once again, OCT can help us in the differential diagnosis. What about granulomas? I feel quite uncomfortable speaking about granulomas to the people that actually taught me how to recognize intraocular TB. OCT is very helpful in identifying and monitoring granulomas in the choroid as well. And once again, you see how it looks similar to the histology. And usually to detect choroidal granulomas, you use ICG. I'm quite sure that Pier Giorgio will show you later that you can also use OCTA. If you combine ICG and OCT, and particularly if you use EDI, which allows us to see the choroid, you can see that you can image choroidal granulomas very well with EDI too. Now, one might ask, how can I differentiate a choroidal granuloma from these, which are, of course, enlarged choroidal vessels in a picture of a patient with chronic CSR? Well, there is a trick that I'm going to show you. They look very similar to each other, but if you look underneath the lesion or the vessel, you will see something very different. In fact, the vessel usually induce a blockage on the OCT signal. So you will see some shadowing underneath, while the granulomas behave in an opposite way. So you will see an increased transmission effect under the lesion. And this is confirmed if you combine the ICG and the OCT. You'll see that the granuloma, which is pointed with the white arrowheads, is accompanied by an increased transmission underneath, while the vessel on the right, which is indicated by the black arrow, doesn't show an increased transmission. So this effect was noted in almost all lesions. So it's something that can really help you in the differential diagnosis. I also want to bring to your attention this report, which focus on the different thickness of the layers of the choroid. And the authors found that an enlarged subtle layer may indicate the diagnosis of sarcoid rather than TB, and which is very important because these two diseases always or very often are similar to each other. So I cannot go through all the features of the different uveitis on OCT, but especially if you look at the OCT of the retina, you have very different patterns, and identifying one of these patterns, this is just a series of examples, can really help you in suspecting different diagnoses. So I suggest you to look at this table. This is in a paper that my friend Francesco Picchi with other colleagues published in Progress in Retina and Eye Research last year. And there is a list of features of non-infectious uveitis and infectious uveitis on OCT. So as you can imagine, I cannot speak about all of this, but you can always go and get the table. So what about the management and the prognosis? I said before that CMV can be recognized for some alterations in the retina. The virus can actually spread through two different patterns. So it can come from the choroid and affect the entire retina, or it can come from the retinal vasculature and go horizontally. And this reflects into two different patterns. So if the virus comes from the back, so from the choroid, the RPE is going to be affected, while if it comes from the retinal vasculature, the RPE is going to be spared. And this has important implications in the evolution of the lesion. So if the RPE is involved, somehow this induces a sort of scar formation, and this will, of course, evolve into an area of the retina which is not working, but is very unlikely to give you a detachment. On the other side, if you see this kind of alteration, like the one you see on the top right, even if the lesion is not very large, the fact that you have disruption of the outer retina and these cavernous spaces is very likely to evolve into a detachment. Of course, there are other parameters that you have to take in consideration. So for example, you have to consider the amount of retina that is involved, and there are studies showing that the larger the area, the more likely you are going to have a detachment. But the pattern of necrosis is also very important. And back to the Candida, similarly, that you can have two different patterns. So it can come from the retinal circulation, or it can come from the choroid. And once again, these results into two different patterns of healing. So if it comes from the retina, of course, it's closer to the vitreous, so it doesn't have to go through many structures. It can get into the vitreous quite easily. So if you treat the patient, you're going to have quite a good outcome, because the retina, especially the outer retina, the RPE and the choroid, are going to be not involved in the scar formation. On the other hand, if it comes from the choroid and it involves the RPE and the outer retina, even if you treat the patient, even if you get to vitrectomy, systemic antifungal treatment, and you get a good scar formation, the outcome is going to be very poor. Once again, it also depends on the position of the lesion, but the two patterns of healing are very different. So what about chorocapillaritis? This is an example of an AMPI. You see that AMPI is characterized by non-perfusion or hypoperfusion of the chorocapillaris. And when you treat the patient, you can have two different outcomes. Once again, you can have reperfusion, or you can get atrophy of the chorocapillaris and the overlying retina. Now, what's very interesting is that with OCT, you can actually predict the way this is going to heal. Lesions are going to heal. If you see these two areas, you see that on top of the RPE, in the area which is encircled by the red circle, you see that there is hyperreflectivity of the outer retinal layers, while the other area, the one in the green circle, doesn't show any alteration of the outer retina. And the one on the left is going to heal with atrophy of the chorocapillaris and the outer retina, while the other one is going to be back to normal. This is very important when you are assessing a patient, because if the lesion is already at the stage of the one in the red circle, even if you give the treatment to the correct treatment to the patient, that area is going to be lost. While if the lesion is still at the stage of the one in the green, you can ensure the patient that he's going to have a good outcome. So let's see how OCT can help you in assessing the follow-up of patients and the response to treatment. Well, of course, the first thing we think about is macular. And of course, we don't have to forget about this, because it's probably one of the alterations that we see most commonly in our patients. And OCT is definitely the technique to use in this case. But once again, we can use OCT to monitor changes and response to treatment in many other cases. For example, serpiginous-like TB, something you are very, very familiar with. We normally check serpiginous-like TB with fundus pictures, autofluorescence, or fluorescent angiography, IC lesion here, the one you see dark on ICG. But we also know that you can use autofluorescence and OCT, and non-invasive techniques. This is an article from Dr. Rima, Dr. Vishali, and they described that the pattern of autofluorescence and the pattern on OCT can actually tell you if the lesion is active, if it's in an acute stage, or if it's healing, or if it's healed. And this is just an example to show you in one of my patients how to apply this sort of monitoring. You see that the lesion on the left and circle on the left on ICG can easily be seen on OCT here. You see a bump, you see a loss of the normal pattern of the choroid at the level of the lesion. And then with treatment and follow-up, you see that there is a good response and the shrinkage of the lesion and a progressive normalization of the anatomical picture. And of course, if we think about the response to treatment, you have to think about choroidal thickness. In fact, choroidal thickness is probably one of the parameters that all uveitis specialists should monitor over time. We know that the choroid gets thicker when inflammation is in the eye because it's a vascular structure and it's very responsive to inflammatory cytokines. So sometimes we don't see many changes at the level of the retina, but we see changes at the level of the choroid. And this was described first in VKH, but we know that basically all uveitis, even anterior uveitis, may have changes at the level of the choroidal thickness when they are active, and then the choroid gets back to normal thickness after treatment. This is just another example. You see, this is a patient which is suffering from VKH, a large bullous detachment of the retina, choroid. And what's interesting is that if you look at the thickness of the retina at the edge of the bullous detachment, there is not much change. But if you look at the choroid, of course, after just a couple of days of treatment, you see that the choroidal thickness changes from this to this. And so if you overlap the two images, you may appreciate the difference. Just another example, serpiginous choroidopathy. So not serpiginous-like, this is the autoimmune version of the disease. You see that there is an active lesion right in the center, and you see that there is a choroidal thickening. And then after treatment, you see that the choroid gets thinner and the lesion involves. You can use OCT to follow also choroidal granulomas, and this is just an example of a large lesion, but you can obviously follow over time even a smaller lesion. And what's very interesting is that if you look at this case, the ICG doesn't show much change, but the OCT, the difference on OCT is quite striking. And the reason is that the choroidal granulomas tend to decrease in size after treatment on a vertical axis way earlier than on the longitudinal axis, on the horizontal axis. And this is just a matter of physics and the resistance they found from the surrounding structures. You can also follow different kind of lesions affecting other structures, such as this large tuberculoma. We were treating the patient for TB and we didn't see a big response here. So we added anti-VEGF and we saw this important shrinkage of the lesion. And once again, OCT was fundamental to follow the changes over time. Another example, this patient with Cryptococcus neoformans, you see that after 4 days, the lesion seems to be maybe less fuzzy, but I couldn't say there is a much change here. While if you look at the OCT, you can easily appreciate that from baseline, you have a shrinkage of the lesion on the B scan. And this is a case of Candida endophthalmitis, where OCT actually helped me a lot in the management of the patient. So you see there is this impressive lesion coming from the choroid and affecting the fovea. So we started the treatment, and what we found 3 days later was that the patient had hypopion. So I was very concerned because I thought it might be worsening. However, when I scanned the lesion again, what I found was that the lesion was actually way smaller and less extended compared to day one. So it was a sort of paradoxical worsening, as you sometimes see in these infectious uveitis. But in this case, OCT was very, very useful in following the patient and telling me that I was actually going in the right direction. So as we are in COVID times, I have added a couple of slides about OCT in COVID-19. I guess many of you must have read this correspondence, so this paper that came out on Lancet last May, and the authors described some features of patients with COVID. They describe small cotton balls, very small hemorrhages in the retina, but then they describe these hyperreflective lesions at the level of the inner plexiform layer and ganglion cells layer, and they say that these lesions could represent COVID lesions. So I was a bit concerned about this because I went back a couple of years in my spectralis and I look at my retina in 2018 and I found that I had the same COVID lesions in my retina 2 years before COVID actually became a disease. So fortunately, I was not the only one concerned. And a few days later, this editorial was published stating exactly what I suspected. In fact, these authors said that what was described as COVID-19 related lesions were just normal retinal vessels scanned, longitudinally scanned with OCT. So far, we have no findings that may suggest COVID, to my knowledge, on OCT. So to conclude, OCT is very commonly used to assess the presence of inflammation in the eye, but I think we can use it in very different ways, in alternative ways that may help us managing our patients. And we can predict clinical outcomes. We can follow the patients using this technique. Is completely harmless. So we can repeat it several times and we can get way more than we think out of OCT. My last suggestion is just this, and this is something I always keep in mind. Technology is just a tool, it's the way we use it that make the difference. So don't rely just on OCT. Use your brain always, and use OCT to suspect something, and then use your brain, your clinical practice, and other tests to confirm your suspect. And I thank you for your attention.
Thank you, Dr. Alessandro. I think that was a beautiful talk on applications of OCT in our uveitis patients. And I'm sure in today's time, we all realize the importance of having these diagnostic tools, but after having listened to your talk, many of us would think how less we are doing with these diagnostic modalities that are available to us. So I think we'll go on to the next talk and maybe take up the questions after we are over with both the talks. So our second speaker is Dr. Neri, and who's currently the Director of Uveitis Services at Cleveland Clinic in Abu Dhabi. He's also the Editor-in-Chief of International Ophthalmology and also the Reviewing Editor of OII Journal. And he has great expertise in another important diagnostic tool which is available today with all of us is OCTA. So over to you, Dr. Neri, and to understand from your vast experience on applications of OCTA in uveitis.
Thank you very much. I'm very delighted to take part to this webinar, and I can tell that I'm glad that Alessandro doesn't have COVID-19 lesions in the retina first. And I'm very delighted also for another thing, just seriously talking about the topic that I'm going to talk about, is that now we are experiencing a new way of interpreting OCTs, not like just to see what the OCT can provide, but also the fact that we can interpret the lesions and we can understand and go through like the radiologists are doing for other subspecialties. And we are taking advantage of people like Alessandro, who is really, considered and is an expert on this field, and can give us, you know, a sort of bright light in the darkness when we are in front of very difficult cases. So let's say that, well, this is my financial disclosure. Well, let's say that, you know, uveitis experts are, you know, the ones experiencing very often a lot of problems. So you can see that when you look at this dog, it's pretty tough to see where this dog is when you have a background like that. So it is important to understand also the fact that, as I said previously, you know, I'm a former, you know, young physician because I had the chance to see the story. So in 1994, for the first time ever, the first OCT has been created. And that was the greatest thing that happened. And this happened, you know, thanks to studies of a Japanese guy that in the United States proposed the machine to Tufts University that then developed the machine later on. So the first publication that came out happened in 1994. And I can tell you that was my first year of university. But, you know, since I don't think I'm, you know, like a dinosaur, I can tell you that in 26 years, a lot of things happened along the time. So we experienced, you know, the development of this machine that was more or less like the one that, that you may see here. That is the Fourier domain OCT, where, you know, pictures are much better than the one provided by the time domain OCT. And here I like to bring, you know, this picture that Christine Curcio published in IOVS in 2011, where you may see that the structure of the OCT can be very similar to the histology that we can provide when we get a flat mount of a lesion. So you can see that things evolved quite rapidly along the time. And as you may see here, you know, roughly in 20 years, you know, we got something much, much different than we used to have. So the only problem is that now we have, unfortunately, LeBron left Cleveland and now he is in Los Angeles just because I think a Cleveland team is not as good as it used to be. But, you know, the OCT now, it's like, you know, LeBron compared to a very crap guy with an improbable haircut like this. So let's say that now we have the LeBron James of the OCTs. And as you listen from Alessandro, you listen that we got a lot for the standard B scan. And of course we can learn a lot, you know, also for the three-dimensional reconstruction of all the lesions that we may have. But we need to think that, you know, a machine can have a potentialities that are unexplored. So that's what happened. So the engineers thought that, you know, images might have been detected by considering the static, you know, status of a tissue, or maybe to study what was changing, you know, along the time in the tissues that were analyzed. And that is just the bloodstream. So they thought, why don't we apply something just to detect something that cannot, that was not appreciated before? So let's say that the so-called, there's this terminology that is a little bit tricky. So it's a split spectrum amplitude decorrelation and geography technology. So this is just an algorithm that it can extrapolate to different peculiarities of the tissues. One is the static. So the static is the one that is not changing, so cannot change. And this is just the static tissue that we have in the retina. But the bloodstream can be detected by seeing, you know, how there's the variation of the stream of the erythrocytes into the vessels. So when you got something like this, you can apply an algorithm and then extrapolate and reconstruct a structure that might, you know, be appreciated in a different way. So this is the proof that when we have 8 consecutive OCT scans of each position, we can roughly reconstruct a B scan that can enhance what is happening in the tissue that you are analyzing. But of course, you know, this is based on 2 different things. One is the phase and the other one is the amplitude. When you have a no decorrelation, you got a static tissue, like the one that we have, you know, when we analyze the standard OCT images. But of course, we can have a decorrelation of the signal, and the decorrelation of the signal can be a phase decorrelation, and this is the Zeiss royalty. So the Zeiss machines are working on this principle. Or you can have the other one, which is the decorrelation of the signal, which is in amplitude. So you have the amplitude decorrelation, and this is what is happening for the OCTA. So let's say that we have different possibilities to apply different algorithms that can give us the visualization of a tissue that was impossible to be visualized, or at least was visualized not in the way that we're visualizing right now. So that is the, probably the biggest change that occurred in the history of OCT. So we started quite a long time ago, and now we can analyze the different layers of the retina, but we can visualize, and fast. So it means that we can see roughly what we can see by a biomicroscopy, or even better, by an angiography. Fluorescein angiography is the first one that was challenged by this new technology, but now you will listen that we got something even better that can give us the opportunity to study the tissues in under different aspects. So we can study the superficial capillary plexus, the deep capillary plexus. We can see the outer retina and the choroid capillaries. But I would say that we will see that we can do even more and go deeper and dig inside, the tissue, and see what is happening in the stromal choroidal tissue, for instance, that was impossible to be analyzed previously. So the most important thing is that we can have potential advantages and disadvantages. Let's say that, I want to approach the problem in a different way, because very often we used to, to consider the fact that, we got mainly advantages and limitations, but I want to tell you that we can understand on how to combine both and try to get some informations that can be then combined to the traditional techniques, and, then at the end, come out with a solution. So the advantages are that, number one, we don't need to inject any dye. So it's a dye-less technology. So we can have a very safe procedure, can be repeated many times with no issues. We have a high magnification of macro flow characteristics. And let's say that one of the limitations of the fluorescein angiography, for instance, is that if you don't catch immediately the early phases, you cannot visualize all the things that can be visualized and extrapolated in the technology that we are talking about right now. Then we have the so-called infectious technology that can analyze the flow anatomy in specific layers. And this is not possible with the other techniques. So let's say that fluorescein angiography, although the machines are much better than the ones that I used to use in the past, and I can tell you that I saw the whole development in ICGA when I started, my training in ophthalmology was something like, wow, we're using the ICGA. It's now a standard that is used all around the world. And I can tell you that now can be challenged by this new technology. So I would consider now the disadvantages for that. Number one, we have no information about the leakage, even though, there are some groups which are arguing about it, because we can use a different technology, not the angi-OCT, but we can use the infectious OCT to analyze it. Limited quantitative tools for now, because we are studying. I would say that this is not a real limitation. So the quantitative tools, so when we need to use the measurements for the lesions by the angi-OCT, we cannot claim, hey, we got everything that we need. Of course, we need to study, and I can tell that the group that's in my clinic, Francesco Picchi, is leading in collaboration with Alessandro Imbermizzi in Milan, is studying a lot about everything can be measured in the different retinal and choroidal tissues. And now we are also running an interesting prospective trial for the study of choroidal lesions in uveitis. And we can tell that, the last one is, well, I would say, quite an issue for every single non-invasive test. We have some issues with the imaging artifacts. And of course, this is one of the biggest challenges that we have to face for research and for the daily practice as well. So when we want to see, the differences, we can see here that the superficial capillary plexus can be visualized perfectly. But of course, the deep capillary plexus cannot be seen by the fluorescein angiography. So this is the biggest advantage that we can have when we have to analyze the advantages in using this new technology. But you know, inflammation is very evil, and you know, when you have to consider the different aspects, you need to see on how to interpret and how this new technology can be useful. Well, as I said, I have the privilege to work with Francesco, and you can see here listed also Vishali, that was one of the co-authors of this publication, published, I would say, you know, quite a long time ago, because in 3 years, you know, he and we did a lot, you know, about that. This is the very first comprehensive review of the literature for the application of optical choroid tomography angiography in uveitis and inflammatory diseases. But very recently, Alessandro and Mario Munca and Francesco were the team leaders for another publication that came out this year. Let's say that it is very important to see that we need to consider what we can do. So let's say that we can just split into two different aspects that might be studied by the angio-OCT. Number one is the retina, so the proper retina, and then the choroidal tissue. So for the retina, we can study ischemic vasculitis. So I think this is one of the predominant advantages that we can you know, consider by using this new technology. Pathophysiological vascular network, so we can see, you know, how there's the remodeling of the vascular network after or during the uveitis. And then, of course, we need to consider that we can study the neovascularization, which is one of the advantages that we can have by using this new technology. Regarding the choroidal issues, the choroidal tissue, I would say that inflammation, like the granulomata, this is just an example, can be explored, and I will show you how we can do, and the neovascularization probably again, because you know this can be studied even at the stage where it is not so obvious by analyzing the standard cuts for the OCT and even for the angio-OCT. So this is just an example on what I'm saying. So when you look at the scans on your left side, and this is one of the pictures that Francesco published in Progress Retinal Research, you can see that the B scan is showing a clear retinal lesion that Alessandro has shown you before. And on your right side, you may see, you know, how the angio-OCT can be interpreted. I would say that is not a fundamental thing to consider that, but you can see how the vascular network improved before and after the treatment. Would it change that much, you know, the prognosis? Can it be important for monitoring the patient? I think so. So I would say that when we combine the B scan, the B standard scan that we used to do and we continue to do during the daily practice, and we associate also what we observe by what we can see by the angio-OCT, we can have a very valid you know, speculation on how the tissue is reacting. And I would say that I'm convinced that you know, Alessandro didn't present the data you know, in the previous presentation just because he wanted to give me the chance to talk about it, but I'm sure that he's making every single time the angio-OCT to every single patient that he has to take care of in his clinic. It is important to see also this. I mean, the deep capillary plexus is probably one of the best aspects that we need to consider when we have to analyze the lesions in the retina of patients with inflammatory eye diseases. Because when you see that, sometimes you may see the retina and it seems to be roughly normal, but when you perform the analysis of the deep capillary plexus, you can see that the impairment of the deep capillary plexus, particularly in the areas which are just approaching the center, so in the foveal area, in the foveal vascular zone, can tell you why the patient may have unit impairment of the visual acuity. So when you consider not only the thickness map, but you analyze the different aspects which are very important on the vascular tissue that might be affected, you can not only have the speculation, but you have the confirmation that you are in front of an issue. And then you can take also all the measures which are required in order to achieve a better control of the inflammatory eye disease. Again, as I said, you can see the microvascular remodeling in idiopathic retinal vasculitis. So when you look at this, you may see that we have vasculitis, which has, you know, clear hemorrhagic components, and you see also the perivascular sheeting, and you can see also the leakage at the fluorescein angiography. But when you look at the angio-OCT, you see how the vascular remodeling happened in this patient, and this can give you, you know, the value on how important it is to analyze the different frames of the angio-OCT first, and then maybe go through the analysis of the fluorescein angiography that can tell you even more by looking at the leakage of the vessels and how they are reacting to the inflammatory process in the eye. Now we have the possibility to have the angio montage, which can give us, you know, a wide, you know, spectrum of what is happening in the retina. We got the so-called Plexelite, which is the new machine that both Alessandro and us and other centers all around the world are using for the study of angio-OCT. We can have the montage of a 12 by 12 end-phase angio-OCT and have the composite that can give us, you know, an area which is a 15:9. So when you look at this, you may see that we can see roughly 70% of the retina. I would say that is not perfect. Probably we're going to get better in the future, but we can tell that this is a big jump forward, you know, compared to what we used to have. And considering that, we can tell that this can change a lot in what we're going to know by using this new technology. This is just an example on what we had. So when you have something like an idiopathic retinal vasculitis, you can see pretty easily the ischemia, so you don't need to have an angiogram, and even by the biomicroscopy, when you cannot appreciate it very clearly, angio-OCT can tell you what. And of course, when you dig deeper, you can see very well that there's a vascular remodeling, and this can be appreciated in this picture in the superior part of the periphery of the retina of this patient, and you can appreciate that this can be one of the possible clinical findings that can tell you a lot about what is happening in the inflamed tissue that you're taking care of. Well, the problem is that, as I said, we have no information on vascular permeability. But I think that here, this is a merit of Mary Munk, which is strongly convinced about it. She said that, of course, when you perform the end-phase OCT in this cases, you may see very well that when you have like a frosted branch angiitis like this, you can have the Plexelite that can tell you the story about it. Of course, I wouldn't tell that this is the answer, but for certain, I would say that the images can give us, you know, an insight on what is happening. Let's say that we can have even, you know, the baseline approach by performing both the dye test, so the fluorescein angiography, and of course the end-phase OCT. But when you want to monitor the patient, it is not really necessary to perform the fluorescein angiography every single time that you see the patient, but you can perform every single time the angio-OCT because it's absolutely safe and has no side effects, and it's a test which is not using a dye. So I don't think that we have to have preconceptions in repeating many times the angio-OCT. That can be a sort of GPS, you know, in the middle of nowhere when you have to take care of a patient with a severe disease. So this is just endorsing a new concept that I think it's important. Very often there was a misconception of a multimodal imaging, like to combine dye test with non-dye test. No, that's not absolutely true. To my opinion, I would say that multimodal imaging is just a combination of different techniques. So we can even combine different techniques, like we use the so-called non-dye test, and then we can combine with the non-dye test, like a standard cut that we can have by the OCT, whatever it's going to be, like Alessandro said previously, and you can have, you know, a very good and reliable information about what is happening in the tissue when you have to take care to something which is going on due to inflammation. So when you look at, you know, the lesion right at the bottom, this is just the B-scan scout view, you may see that, you know, this is a lesion in the choroid. You cannot tell whether this is a neovascularization or not. Probably, you know, persons which are very expertise, like Alessandro and Shali and the other colleagues here can tell. But of course, when you perform the angio-OCT, you can see that inflammatory CNV can be easily seen over here, you know, in all these aspects. And then you may see that you can appreciate the location, the morphology, and you can even, you know, bring up, you know, new concept on the angiogenesis and think about it. And of course, this is very, very useful for the follow-up. Now, we are approaching probably, to my opinion, the most interesting debate in the history of OCT. So these two persons here are Carl Herpot at the top of the slide and Larry Iannuzzi at the bottom. So both were really involved in the study of ICGA in the field of retinal Iannuzzi and uveitis Herbert. But I can tell you that, you know, even though Iannuzzi is acknowledged as a worldwide super expert for retina, he had a passion for white dot syndromes and particularly for the mutes, because he was one of the very first, or even the very first, who described this concept with Glenn Jaffe. So when you see the ICGA concepts are mainly based on hypofluorescence, so the mass effect, like in TB, sarcoids, and granulomas, and then you have also ischemia, placoid disorders, and RPE mottling in mutes. I wrote RPE mottling just because I didn't want to tell you the story or what I think for real, because you're gonna discover just in a few seconds. So this is the Saint Graal, which is, you know, into the uveitis business. So is this the myth or a reality? So let's say that this is the big question. So this is an unsolved question. Can ICGA be replaced by angio-OCT? That's a very good question. Actually, I don't have the answer, I mean 100%, but I can tell you that I'm quite convinced that, you know, the direction that we are, that we took, it is the correct one. So let's say that, I mean, I'm Italian, and as you may know, and I do really like philosophy and the ancient philosophy that was belonging to the Roman Empire. So let's say that we have a statement which is in medio stat virtus, so means that the truth is right in the middle. And I can tell you that we can even use this statement, this quote, for what we saw for angio-OCT and ICGA. So let's start with Glenn Jaffe. So Glenn Jaffe, so in 1984, when we saw that the multiple evanescent white dot syndrome was described for the first time. So let's say that in 1984, multiple evanescent white dot syndrome was described for the first time as a lesion that had, you know, this multiple whitish areas that were, it was lesion pole, I'm sorry, so I had a lapsus. So this lesion pole described this like, you know, multiple whitish lesions that were affecting the retina. So there were unilateral white dots, and there was also foveal granularity. So this was the first thing that was described. Fluorescein angiography presented very little, but we saw that there was an impairment of photoreceptors as per what has been described by the electroretinogram. And then there was also late hypofluorescence at the ICGA. So when you look at it, you may get the point that, you know, something happened in the retina, but was not really clear where this happened. And there was a speculation in the past that it was a lesion that was affecting the retin pigment epithelium / the choroid capillaris. So when we looked at it, we saw that there was COST disarray, and there was a thickened choroid, which is common in what we observed at the standard cut by the OCT B-scan. So mutes, is it really an ischemic choroidocappilaropathy as Professor Herbert insisted to say? Well, actually, when we look at the autofluorescence, we see that there are hyper autofluorescent lesions. And actually, you know, this might be provoked by an ischemia that is creating a hypermetabolism of the retinal pigment epithelium. But I would say that we don't have the proof of nothing, you know, by seeing this. When we look at it and we think, well, yeah, probably, you know, we have an ischemia because there's a hypofluorescent lesion. Well, we may think that, you know, this is probably the case. But when you dig deeper, you probably see something different by using this new technology. Because by Angioplex, a publication that, again, Francesco made, has proven that the choroid capillaris doesn't have any anomaly. And as per what we said about the peculiarities of angio-OCT, when we can visualize the tissue and the bloodstream is normal, we have, of course, the reason to think that this is not impaired. So let's say that as per what we saw, by the standard choroid capillaris visualization, we don't think that this is a choroid capillaropathy, or an even more an ischemic choroid capillaropathy. So when we look at it, we see that the end-phase OCT, we see that, you know, there are blackish areas over there, and, you know, this is up to the retinal pigment epithelium, or even, you know, it's not retinal pigment epithelium impairment, but it is something different. So let's say that this publication that's, you know, it was published quite a while ago, was arguing whether, you know, this was probably, you know, something different. Actually, the lesson learned in mutes, you know, starting from 1984 until now, is telling a different story. So retinal pigment epithelium normally absorbs ICG, causing physiological background hyperfluorescence. ICG uptake, however, may be disrupted in certain retinal disorders, and I would say that mutes might be one of them. And this can explain the late hypofluorescent lesion. So now, you know, there was a big debate about the fact that Carl was telling that the visualization of the choroid capillaris cannot happen because the intravascular pressure is too low to be visualized. And I was telling the contrary. So, well, when you don't know the answer, it is better just to go back in history and see what has been done in the previous past. So let's say that, you know, when we see this publication in Expert Eye Research in 1992, Mipea, that was a basic researcher, published the intraocular pressure and the choroidal venous pressure and the choroid capillaris pressure. Actually, you know, the choroid capillaris pressure is higher than the choroidal stromal pressure, which means that the bloodstream can be pretty easily visualized and the angio-OCT can be capable of that. So let's say that we can trust the fact that the choroid capillaris can be visualized, and for certain, there is no obvious ischemia that can occur during mutes. So as per what we discovered, mutes is not a choroid capillaris ischemia. Moreover, we can tell that there's someone who said, well, I cannot see by using spectralis, for instance. Well, actually, when you look at this chart, and there is not, unfortunately, the description of what Plex Elite can do, but I will show you the pictures telling you the story in a different way. You may see that not all the angio-OCTs are exactly the same. Let's say that spectralis cannot visualize the choroid, and I can tell that cannot even visualize the choroid capillaris. So it's an excellent, excellent machine to visualize the standard angio-OCT, so the one up to the retinal vessels, but you cannot visualize the rest of the story. So of course, we need to keep in mind that we have to differentiate the different machines, which can have a lot of, you know, qualities, but cannot have some others. So let's say that it's very important to pay attention to the varieties of machines that we have and consider the one that we are using. So looking at this picture again, we were thinking that the granularities again, might have been done to something that happened, in the retinal tissue. So when we look at it, we can even think that this is a photoreceptoritis. So this might be the case, but for certain, it is not a choroidal ischemia. So the take-home purse for mutes is that we need to associate the multimodal correlation of the hyperreflective dots. So when we look at the retina, we can see the hyperreflective dots we see here, which is a novular material in the O and L. And of course, we need to consider the fact that there is no evidence that something happened in the choroid capillaris. So probably this is just a retinal affair. And we need also to pay attention to the autofluorescence, which is telling us the story, as well as the multiple ones we can see in different sites as per the distribution of the different lesions, as you may see here in the autofluorescence, and of course, in the other picture that I'm showing you here in this slide. But now we can tell that the greatest thing for the research is represented on how we have to dig even deeper. And what about the choroidal exploration? So what about the stromal choroidal tissue? Well, the stromal choroidal tissue probably was, and will be the biggest challenge that researchers, which are passionate in studying the angio-OCT, have to go through. Let's say that the most important thing is the fact that now, as I said, we can have a wide field OCT. So before we had a very limited area that might have been studied, but now we have the chance to visualize the broader component of the tissue, and we can go through it and analyze it in a very picky way. So when we look at this, this is just a wide field indocyanine green angiography. You can see that there's a huge quantity of stromal choroidal lesions, which are granulomata. And this is the first picture that when you look at it, you can understand that you're in front of TB, like in this example, but I can tell you that this can be the same also for other lesions like birdshot, Foucault-Yanagia rata disease, or maybe even sarcoid, even though multifocal choroiditis is not very often observed like this in patients with sarcoidosis. But let's say these are undisputed choroidal granulomata. But when you overlap this to this picture, which is exactly the one that we can get by this new technology, you can see that the difference is not that much. So when you look at it, you can have the feeling, because until now, we didn't have the proof that we might have had the same type of results by comparing fluorescein angiography, indocyanine green angiography and the angio-OCT, to tell that both the machines are telling the same story. But we had the feeling of that. But now we have the proof, because thanks to, again, these two guys, which are the very young ones, in ophthalmology, Francesco and Alessandro, we published together a paper that is probably the breakthrough of, the dispute that is in between indocyanine green angiography and the angio-OCT for the choroidal exploration. Let's say that it is very important to see that we have hypofluorescent lesions which are perfectly, overlapping to the voids. And we can tell also that in 197 over 209 granulomas, studied with an analysis of two blinded observers, the matching was in 94.3% and had the corresponding round area of flow void at OCTA. And of course, this was interpreted as a granuloma. So when you look at it, you can really feel that, this publication that, came out very recently is telling you a lot of stories. And again, we can see also that, this brought up also the hypothesis that when we saw in 180 case, the fact that we had 104 round flow voids at OCTA, did not have any corresponding hypofluorescent lesions on ICGA, we have speculated that probably, you know, what we have seen by the angio-OCT might have been interpreted much better than the one that we achieved by using the ICGA. So let's say that now the story is reverted. Might be angio-OCT better than ICGA? It might be. Of course, we need to run something that is prospective, but I can tell you that we are doing this already because now Alessandro is leading a prospective research on that, and we're very looking forward to giving you the results in the near future. But moreover, when we look at that, we saw also the correlation. The biostatistician wanted to have the blind Altman analysis that was performed, and we saw that the magnitude of difference in the mean lesions across their cross-sectional areas as measured as per OCTA and ICGA was done in the study. And we saw also that the proportional difference in the areas measurement was in favor to OCTA. Because when we look at it, we can see that the mean area of 197 lesions that were detected with both imaging modalities was significantly larger in ICGA, with a mean of 0.33 millimeters square compared to OCTA that was 0.28. So let's say that it might be the case that the sensibility of the machine in detecting the granulomata, of course, we don't have an artificial intelligence, you know, giving us the opportunity to analyze it, but we can tell that we have the advantage in having the chance to see the lesions, you know, when they are even smaller, and we'll look at that. Of course, when we have a chronic VKH, like, you know, the sunset glow fundus, and you perform, you know, the lesion, you can see how beautiful are the images. And when you look at the lesions, the larger one, you can see also, you know, some vessels passing through a sort of empty space that is just the atrophy provoked by the lesion, by the disease per se. And you can appreciate very well, you know, that how this is very similar to ICGA. But now that we have the chance to use the composite, you may see that even though we can analyze different areas and we mount all together, these are absolutely the same. So why do we have to perform an ICGA when we have this technology? But even more, we were going through, you know, the speculation on how this can be interpreted. So on your left side, you may see the normal choroid. So ICGA can fill the stromal choroidal tissue, and then we have the filling of the choroid capillaries. This is what happens in the normal tissue. When we have an active disease, we have the granulomata, which are just a pooling of different cells, which are lymphocytes and granulocytes. And when you see it, you may see that this is squeezing the tissue, creating space. And of course, when we have the ICGA, we can see that we have an anomaly of the tissue that, of course, can show how the granulomata in the different phases of the angiogram can be visualized. So it's very important to pay attention to the early phases and the late phases. And when we have an inactive disease, we have the involution of the tissue, but of course we cannot have an empty space. We have also vessels which are collapsing from the choroid capillaries, and the ones which are impaired, you know, creating a sort of fake empty space that can be visualized like this. And you may see also that the hyperfluorescence might be also the collapse of the choroid capillaries in the void of the tissue provoked by the involution and the scar tissue that later on can be observed much better at the angio-OCT rather than by the ICGA. I want to show you this picture. This is not ophthalmology. This is the standard of care, the gold standard of what is done for a stroke. So when you have a stroke, no one is telling that it's wrong to take a CT scan. No one is telling that you cannot have maybe, you know, an angio-MRN or maybe an angio-CT. But of course, nothing is better than an arteriography. So let's say that we can have different stages of where we can use different kind of tools. And I, as an ophthalmologist, and you, as ophthalmologists, you should think the same, and the scientific community should be oriented towards this direction. So now, just to conclude, what are the take-home pairs? OCTA is progressively reaching a primary position in the background assessment of uveal inflammation. The potential development of this machine has been not explored completely yet. And I can tell you that I don't believe that fluorescein angiography and ICGA should be kicked out from the business, but they should be considered for super selective cases when the angio-OCTs and the OCT cannot give us the answer. And of course, we need to be ready to use the multimodal approach. And remember, this is my team, and I would like to thank everyone, you know, for the help for these beautiful images and presentation. I want to tell you that, of course, we need to be brave enough, and of course, we need to have the step first in order to have better results in the future. Thank you very much for your attention.
Thank you, Dr. Neri. I think that was indeed a very exhaustive talk on OCTA, and it beautifully highlighted the various applications of OCTA. And I think we are all gradually learning to use this tool, though we are not very well versed as of now. But I think there is more to it in future. So the session is now open for questions, and we are joined by even Dr. Anirudh and Dr. Padma Malini. So we'll take up a few audience questions which have been posted to all of us. So one question is by Dr. Anamika, who has asked that MUDES is thought to be photoreceptoritis or choriocapillaritis. What if there's an overlap, and what is your take on this? So it's open to the panelists.
I think you have to ask which one.
Was I audible?
Yes.
You have to ask a particular person, maybe.
So maybe Dr. Alessandro, you can take up this question.
Well, I guess the fact that Pier Giorgio showed that choriocapillaris is spared according to the OCTA is suggesting that the disease, or what we see on OCT and ICG, is mainly affecting the outer retina, maybe the RPE as well. But the choriocapillaris doesn't show much changes. So I would probably say that MUDES is more, in my opinion at least, according to what we have so far and what imaging is telling us, is more something affecting the outer retina rather than the choriocapillaris. But I think Pier Giorgio should answer, as he spent 10 minutes on this. No?
Yes,
Come
I
on.
think he very eloquently explained how it's a photoreceptoritis, and there is the affection of the ellipsoid zone specifically in MUDES, and there is a normalization of the choriocapillaries as seen. And I think Dr. Neri may like to again just reiterate how RPE can absorb the ICG dye, and so you can have abnormalities on the ICG, but you may have a completely normal OCT angiography.
Yeah, I want to just to stress the fact that, you know, I don't believe to my opinions, I believe to evidences. I mean, the evidence is that, I mean, there was, you know, the discussion about the possible lack of evidence of, well, there was the speculation, it was not even lack of evidence. It was just a speculation that the, you know, the hydrostatic pressure into the choriocapillaris was not sufficient to be visualized by the angio-OCT. But I think that even the animal models, as you know, have proven this. So, I mean, it's undisputed that we have to rely the fact that, you know, the intravascular pressure is enough and can be detected. So I believe that is a photoreceptoritis.
Padma, would you like to say something?
I agree with them. It is basically a photoreceptor and outer retinal disease. The choriocapillaries are spared as far as the evidence is concerned. And also in our experience,
photoreceptoritis it is. Yes, Manisha.
outer retinal involvement and not the choriocapillaries.
And there's a related question which has been posted, that why do you see the foveal granularity in this? What is the reason behind that? So maybe Dr. Neri, you can take up this question.
Yeah, I mean, it is very difficult to tell because, you know, there was a lot of discussion, and I want to ride the wave of, you know, this question just to extend it to what has been speculated about the diabetes as well, because, you know, there's people claiming that there are microglial cells, which are, you know, the ones, you know, seeing in diabetic macular edema in severe ones. I can tell you that I can't think this might be, you know, microglial activated cells, question mark, because you can see that they disappears later on. But of course, I don't know exactly the answer. I may think that these are just cells that later on disappear, because when you repeat the angio-CT / all the other OCTs, you may see that, you know, they disappear. So this might be just a temporary, you know, activation of the tissue, even though at the foveal level, and only at the foveal level, this can persist. So we don't know actually, you know, what it might be specifically, but I believe that this might be the case.
And I have another.
I think Anirudh wants to add, Manisha.
Yeah.
Yeah, I think I'm just going to separate out from mutes just to ask Alessandro something that we all would like to ask. How do you obtain such beautiful images? What should we do in our clinics to get such beautiful images? And I'm going to ask you another question just to add on to this. There's a question by the audience. How do you prefer to measure the choroidal thickness on OCT? Do you do it manually by calipers, or do you do automated calculation?
Well, first of all, thank you. I think we all can obtain great images. It's just a matter of spending time using the device. So what we do, I don't know how it works in your centers, but I've been seeing in other centers that there are technicians taking images, and they do their work very well. The problem is that sometimes they do not know what you're interested in. So you have to have a very good relationship with your orthoptist or, you know, photographers or whatever, to ask them precisely what you're interested in. In my place, in my center, we do not have many technicians, so we end up taking images by ourselves. And this is why sometimes, you know, you are in front of the device and you want your attention is caught by something, and then you spend maybe 5 minutes just imaging that precise lesion. And that's the reason why sometimes you end up having beautiful images that you may have lost if someone else is taking the picture. So this is what I suggest. If you have technicians, it's amazing, but you have to go back to them and ask, can you please repeat the scan or, you know, that picture on that specific lesion? This is the key. And regarding the question about the choroid, so it really depends on your goal. So if you have to measure the choroid, I normally do it manually in my clinical practice because it's offered by the device usually. So you have the caliper and you can just assess the thickness. Sometimes I just use, I don't know how many of you use the Spectralis with the EDI, but there is a function which is embedded in the standard software, and you can click on this button and you see a pre-post image overlapping. So the device switches between back and forward between the previous visit or the baseline visit and your visit, and you can easily see the choroidal thickness changing. So that's something I normally do. For study, so for research purposes, of course, you have to be very accurate. So I tend to, measure the choroid twice from different operators, or sometimes to have a software that can segment the choroid, but then I have to go back and check if the segmentation is correct, because the choroid is absorbs a lot of OCT signal. So sometimes the quality of the image at the outer boundaries of the choroid is not good enough for a software to be able to segment the boundaries, to find the boundaries.
So, Anirudh, I'll put the next question to you, since you have a lot of experience in dealing with granulomas. So we have a question that how would you differentiate between multiple choroidal granulomas of TB and sarcoid on OCT images? Any tips for that?
So on the OCT, when you do an EDI OCT in choroidal granulomas, as Alessandro has very effectively shown, there are certain clues that point towards sarcoid and certain towards tuberculosis. If you have a TB lesion, largely it would appear lobulated on the EDI OCT. So it would have an irregular appearance, whereas sarcoid granulomas are mostly rounded, more well-defined on the OCT, and they're horizontally oval compared to the granulomas of TB. The granulomas of TB also tend to be full thickness, much more compared to sarcoid, which can be partial thickness on the EDI OCT. On the OCT angiography, we recently have submitted a manuscript in review in AJO, in which you can actually see that there is a difference between the two conditions, wherein you have TB will have much more vascular changes in the granulomas in terms of wrap lesions and much more exudation compared to sarcoidosis, and this has something to do with the increased levels of VEGF that you encounter with TB granulomas. And just to allude to that, Alessandro has shown in his presentation a very beautiful image of an optic nerve head granuloma, which he also treated with anti-VEGF agents. So I think these are some clues that you can have, but of course you need to also look at the lab features, because Francesco has published a patient of vascularized sarcoid granuloma. So you can have vascularization even in sarcoidosis, and it's not absolute to get it in TB.
I think nothing is absolute in science, so it has to be the overall investigations, clinical presentation, and getting the clues. Like he showed beautifully in toxo, but it can be also in viral. So it's more about getting the clues and the chances of where it is going to be. But that's a very interesting paper, which we hopefully see in print.
In addition to what Dr. Anirudh has said, there are two more things. Satellus layer is commonly involved in sarcoidosis. The ratio between the satellus and atlas is more in sarcoid compared to tuberculosis. As told, more of exudation, we see it in tuberculosis. It is associated with exudative or SRF fluid we see commonly in TB compared to sarcoid. However, there are few reports of minimal SRF has been reported in sarcoid as well.
Right. So thank you for all those tips. And I have a question for Dr. Neri, that what are those flow void areas suggestive of that we see in VKH in the CC slab on OCTA? What's your interpretation of those flow void areas?
Well, the flow void areas, depending on the stage of the disease, when you have, an inactive disease, for instance, or maybe you see that along the time this is changing. I mean, you need to interpret not only on what you see to core. So I'm not gonna, just perform an angio-CT and tell, well, this is active or non-active, or this is a scar, this is not a scar. Depending on the status of the retina and the other images, I can interpret it. So I match and combine by the multimodal imaging, the B-scan standard, what I see by, well, I pay attention also to the autofluorescence as well, that can tell me, the possible nature of this void. So depending on, how the different images are matching, I can tell whether this is an active lesion or not. So let's say that when I have a big granulomata in the choroid and I see that, this is in an active stage, of course, I can think that this is a reactivation. But when I have, some of the voids which are observed at the angio-CT that are reduced, I presume that this is an improvement. And when there's an increase, of course, I can think that, the perimeter of the lesion has been, worsened by a reactivation of the disease. But of course, I don't interpret, this is an active or inactive. Of course, I need to monitor the patient because, until now, we don't have, a biomarker that can tell us that this is an active lesion or not.
So there's an interesting question by Dr. Sudha. She's a senior uvea specialist from Shankar Nethralaya. And she's interested in knowing what would be the features of azure on OCTA. And even I was interested that recently I saw a patient, the fundus was absolutely normal looking, and I was wondering if there is any diagnostic tool which will help me to pick it up in that subclinical stage. So
what was the OCT like? what was the OCT like in your patient?
So OCT is
OCT.
absolutely normal.
Normal.
Yeah,
Autofluorescence also
normal, ma'am.
Visual field also normal.
Visual field, extreme periphery, there is a little depression, but the rest of the field is okay. And on ERG, the oscillatory potentials were decreased, but the photoreceptor responses were not so depressed. They were very minimal amplitude depression was there.
So would OCTA offer any advantage over all this? That's the question. Anyone can take up.
Yes.
Probably, I think Azure is more of a inner, sort of outer photoreceptor issue and not really a choroidal or choriocapillaries issue. So intuitively, I think the OCT angiography may not add information to over what we already get from the OCT. I think OCT and the fundus autofluorescence would be, I think, the way to go. But I have not come across personally any papers on OCTA in Azure, and I think that would be interesting to read.
I would just presume that probably the deep capillary plexus might be affected, but I'm not sure that is going to happen. I mean, it's just because of, the closest position compared to the other components, but I wouldn't think that, it's going to add that much.
And there's another related question by Dr. Sudha, that how would you pick up an inflammatory CNVM in the peripapillary area, especially when you are dealing with a disc edema and acute VKH on OCTA?
Oh, well, that's interesting. Well, actually, I would prefer even to have an angio-CT rather than fluorescein angiography, since, sometimes when you have a swollen disc and you don't catch, exactly the very early phases, you can have troubles. So while with the fluorescein angiography, we can see the leakage at the end, at the late stages and late frames, and we can think, oh, well, this is maybe a choroidal neovascular membrane. With the angio-CT, you pay attention to the morphology. When you look at the morphology of the lesion and you can just crop, the different images and go, layer by layer, you can get it much more easily by the angio-CT rather than by the fluorescein angiography. So nowadays, I prefer to perform the angio-CT. If I'm uncertain, I can even, perform a fluorescein angiography and see, how the two images are combining together. But I think that, even though you have the swollen disc, if you go layer by layer, you can catch it.
I think the key is in the segmentation, the right segmentation on OCT angio if you want to pick up those new vessels. But if at all something is going to show, it is angio-OCT, not the fluorescence in presence of hard disk. Yeah.
If I may add, in addition to the slabbing, will show fine dense network of vessels in the peripapillary region. With the morphology, we can diagnose the CNVM.
Absolutely. It's so clean. There is no noise.
If I may add something, I completely agree. Yeah, I completely agree with you. When you have a lot of inflammation in the eye, OCTA, the fact that OCTA doesn't have leakage is actually something that helps a lot in differentiating inflammation from new vessels. Yeah. So if you're dealing with peak or multifocal choroiditis and you have a lot of inflammatory lesions, they may look similar to CNVs on OCT, on standard OCT. They may have leakage on fluorescein, but on OCTA, you see the difference between the CNVM and the inflammatory foci, as well as Giorgio said for the optic nerve head. If the optic nerve head is leaking on fluorescein, you see a lot of leakage and you can't differentiate the membrane. But when you look at the OCTA, you make the difference. And as you said, Vishali, if you look at the B scan on OCTA, then you may realize the actual layer where the new vessels are. So I always suggest to combine the unfast image of the OCTA with the actual B scan with the flow signal on it, because then you are able to see where the vessels are, and then you can make the difference between retinal vessels, neovascular membranes, and all the others.
Right. And when the disc is swollen, it's going to leak. So the fluorescein really does not give you
Help.
any additional information. Because if your concern is a juxtapapillary membrane, I would just do OCT for the rest of the thing and angio-OCT. I would not even bother to do fluorescein. And the
Absolutely
second
agree.
thing is about PIC. With PIC also, even during the active stage, we are seeing underlying new vessels, new vascular membrane, which we always thought earlier that only when the disease is inactive, are they healed, you will see. And the same is true for serpiginous like choroiditis. There is so much of noise on fluorescein that you can't really make out a small, tiny membrane, which you can in angio-OCT.
So I think those are the specific situations where OCTA would score over an FFA in identifying these, subtle neovascular membranes. So Dr. Neri, I have another question for you, that you see these specific changes on ICGA in MUDES. Are there any other disease entities where you see this specific RPE affection on ICGA other than MUDES, and why is it so unique to this particular disease entity?
Well, actually, I mean, the pattern distribution of the lesions, considering the fact that I don't believe it is a retinal pigment epithelium disease. MUDES, I think it's, as I said, a photoreceptoritis, but it can affect, indirectly the retinal pigment epithelium. When you see at ICGA multiple lesions and these are patchy, you can think about APM-PPE, which is another one that can affect, the choroicapillaries at the stage, which is, the word APM-PPE is not the one that I would use. I would use rather than AMIC, that has been proposed by Deutschmann in '67, long time ago, when Donald Gass in the United States proposed MP. But these are, the most typical ones. When you see, lesions like this, I wouldn't confound the twos. I think that, if you perform an ICGA and you see, the pattern distribution, I wouldn't be uncertain between MP or the MUDES. I mean, I would go for MUDES, even though now I wouldn't go for an ICGA for that. Thinking about other lesions, considering, how the lesions are described, as I said, the pattern distribution, I don't think that we have to confound the different ones. Let's say that the multifocal choroiditis cannot be confounded. We cannot confound, other diseases like serpiginous or amphiginous due to the pattern of presentation. So I believe that, MUDES is pretty unique. And MP has a different, way of presenting, so I wouldn't confound the twos. So I would say that, these are pretty unique.
So Anirudh, I have a question for you, that would you be using your ICG, or you would prefer to use OCTA when you want to stop treating your patient of VKH? I mean, what would be your preferred modality to, follow up your patients of VKH?
So what we typically do is we do obtain an ICG at baseline, and in the presence of subretinal fluid, we try to obtain an OCT angiography at baseline, and within the amount of fluid that's present, we try to identify if we are seeing any flow void areas in the choriocapillaries. Typically, if the patient is on intravenous methylprednisolone in the initial acute phase, I would like to do an OCTA every day for the initial 3 to 5 days of the inpatient treatment if the patient is admitted with us. And if the disease is less severe, I would like to follow up the patient on OCT angiography, at least for the first couple of months of the disease. I would not like to repeat an ICG before 3 months of treatment at least, given its invasive nature. And we have shown in a publication in Ocular Immunology Inflammation in 2017 in VKH, OCT angiography is very sensitive to detect the change in the flow void areas in the choriocapillary slab. And if you are tapering your steroids, or if you are tapering off your immunosuppression, OCT angiography is very sensitive in picking up worsening of the disease. And it correlates very well with change in the choroidal thickness. So if your choroidal thickness is going back up again, it correlates very well with the increase in the flow void areas on OCT angiography. So I feel that OCT angiography is very useful in the follow-up. And if you have a patient whom you're monitoring has chronic VKH and you need to decide on tapering the immunosuppressive therapy. In those cases as well, OCT angiography is very useful, because if you feel that there are flow void areas that could really indicate subclinical disease, and that could be an indication for you to repeat your fluorescein and ICG to detect any subclinical disease, and also so for you to be aware that you need to again go ahead and measure the choroidal thickness. So I think OCT angiography does add value in the follow-up of these patients.
Any other comments from any of the other panelists?
Manisha, coming to the question whether for stopping, they were asked specifically, for stopping the therapy, like Dr. Anand said, frequent follow-up OCTA is useful since it is non-invasive, and OCTA is more sensitive compared to ICG because it detects more number of choroidal granulomas in the published literature. But for stopping the therapy, we wanted to be 100% sure if the patients can afford. ICG is the preferred method because we can go up to the periphery, whereas with OCTA right now we have a limited field of view. So we follow up, we wanted to be really sure, then ICG will help us to confirm that there is no activity for sure. Preferable to have combined both the methods to confirm our observation that there is no activity.
Thank you. So we have an interesting question by Dr. Ashish, who says that at the time of presentation of choroiditis, like TB choroiditis, we have multiple flow voids on OCTA. But after we've treated the patient, some of these void areas still persist. Is it just because we are looking at the areas of no flow due to space occupying lesions? Or is it because they have regressed? Or is it because the disease is still continuing, or there has been an incomplete resolution? So how do we really go about interpreting these persistence of flow void areas on OCTA? And especially when ICG is not available? So maybe Dr. Neri can add to that. Or
yeah, I mean, in the publication that I showed you before, there's the speculation, because we don't have an answer. Because to have a correct answer, we should tell clearly what might have happened in the tissue and have a biopsy. But of course, we can't do that. So we think that the void might be just a scar tissue that is still there, and the fluorescein angiography has can mask by the story that I showed you by the cartoon. So you may see that in some cases you can see the void at the OCTA, but you can see the hyperfluorescence at the late stages of the fluorescein of the ICGA. So this can happen that when you have a scar tissue, the scar tissue, since it is, there's no stream, there's no bloodstream inside, it's just a void. And this is just, something that is resembling, the granuloma that was active before. Maybe the dimension is less, but of course, I don't think that this void can be interpreted as an active lesion to core. Regarding the ICGA, when you see, these areas in one of the pictures that are part of the publication, you may see that you can appreciate even a hyperfluorescence. And the hyperfluorescence might be the choriocapillaris that is collapse into this sort of empty space in order to fill it. And then you can have apparently a hyperfluorescence provoked by the filling of the choriocapillaris in the late phases of the angiogram. So I think that we don't have an answer on what it is, but of course, by combining the different techniques, or maybe by combining the standard cut by the B-scan OCT and the angio-OCT, you may come up with some good and reasonable answers, but we don't have an answer yet.
Thank you. Dr. Alessandro, there was a question posted earlier that if you could again tell everybody how you really differentiate between a choroidal granuloma and a pachychoroid vessel. I think you beautifully showed it in your presentation.
Yes, I read the question. So when you look at the large vessels, usually you see they look very similar to choroidal granulomas because they appear hyperreflective on EDI. So you see this round shape, hyperreflective, let's say, lesion or formation within the choroidal space. But if you perform an EDI, or if you have a subsource OCT that allows you to penetrate the choroid pretty well, you see that underneath this lesion, if it's a vessel, you're going to see a shadowing, while if it's a granuloma, you're going to see an increased transmission effect. Now, the reason or the explanation for this is to be searched into the very nature of the two entities we are comparing. So the granuloma is an aggregation of cells. There is no flow inside the granuloma, and they are quite uniform in terms of interfaces that the signal faces when it gets through it. So the signal can pass easily through something which is very, very compact, and it is not scattered. On the other hand, if you have a vessel, you have the signal has to go through the vessel wall, then it gets into the flow of the bloodstream, so it's scattered around, and you have and this induces this shadowing underneath the vessel. So if you look, you don't have to look at the lesion itself, you have to look just underneath, and if you see a shadowing is a vessel, if you see an increased transmission, is more likely to be a choroidal granuloma.
Yeah, so thank you so much. I think that beautifully clarifies what we see there. We just have last few questions, which I'll quickly take up. One is that please explain the precise technique for segmentation in OCTA. I don't know if this is possible here, but if any one of you would like to add a few tips on segmentation.
Well, I think you just, Giorgio, do you want to answer?
No, go ahead. I mean, I took too much.
No, I think it's just, you just have to be careful about the segmentation, because if the retina is normal, the segmentation is going to be correct, because the algorithm is designed on, is trained on normal retinas. When you have alterations of the layers, then the algorithm may be tricked, and so may do a lot of mistakes. So there is no standard segmentation. I mean, you have presets, but then you have to look at this slab, so where the lines are put by the algorithm, and you have to interpret the images accordingly.
I want to just to tell a brief thing to this colleague is that there's, well, number one, of course, this is exactly what we would expect for a correct segmentation, but there's also another issue which is related to the machine. Number two, to the technology that is used, and number three is the fact that there is not only a superficial capillary plexus and a deep capillary plexus, but theoretically, on the basis of some publication, there should be also mid capillary plexus. But people is making the things very complicated sometimes. So let's say for the standard activity that we have to run on the daily practice, I mean, we have the machines which are capable to segment automatically. But of course, when you have, for instance, vitreitis that can create artifacts, just spend time to do it manually and try to help the machine to surpass the problem, and then you can have, the correct answer on what you're gonna have.
So any last comments from anyone, any one of the panelists?
I think just to add to that, it's very important to just sit with the machine, to sit with the OCT angiography, spend time on the device, spend time with the OCT. And I think you learn segmentation and other things, on your own, but you need to spend time, and rather than rely on automated reports or just printouts, I think it's important to spend time with the device.
Yeah, Padma, you wanted to say something?
Yes. Normally, wherever we see the area of focus, you focus that area and get the more slab or more sections and concentrate on that area of pathology. In addition to the choroidal thickness, in assessing the disease activity, which has been told by Dr. Alessandro, we can do choroidal vascularity index that has been reported by Dr. Rupesh and also Dr. Vishali ma'am team, and where we calculate the ratio between the lumen and the stroma. It is more in acute cases, and in chronic, for example, we have published in case of VKH, where we noticed the CVI was more in acute cases, but when the lesion resolves, there is a choroidal thinning and the ratio is also decreased. It's another method where we can assess the disease activity in case of a choroid. And OCT can also be used anterior segment in addition to assessing the uveitis in studying the scleritis. Exactly, we can measure the depth of the sclera and also to differentiate between episcleritis and scleritis can be used. Then another point, OCT, in addition to uveitis, we also use as a diagnostic marker whenever we suspect a case of masquerades, either in case of a leukemia and lymphoma. Especially in leukemia, we can see the hyperreflectivity, which is seen within the vessel lumen, which has been reported by Dr. Anirudh and team. And also in lymphoma, we have a specific OCT markers such as sub-RP deposits and also the vertical linear deposits on the retina. These findings helps us to make the diagnosis and also monitor the response to treatment in case of masquerades.
Thank you, Padma, for these important tips that you have added. So I think we've had an extremely interesting session today with a lot of questions and discussion. And I think that at the end of the day, the last slide of Dr. Alessandro said it all, that we are first clinicians rather than technicians. So we have to first make a clinical suspicion of what we are dealing with in the patient. And then all these diagnostic modalities which are available in our clinics like OCT, OCTA, FFA, and ICG would just help us confirm in what we are clinically suspecting, but surely they are not going to override our clinical judgment. So OCT and OCTA, of course, are very important because they are non-invasive. And earlier on, we used to always be hesitant in repeating the invasive tests, that they have their own set of complications. But for tests like OCT and OCTA, we really don't have to think twice, and we can keep repeating them on patients every visit, and they really help us in seeing what is the response to our treatment that is being given to the patient. So I think beautiful images that we got to see, and Dr. Vishali, she rightly mentioned at the start of the session that it would be a delight to see the presentation of both of you. So thank you so much for sparing your time and effort. And I think it's been a great learning for each one of us who attended the session today. I would also like to thank Dr. Anirudh and Dr. Padma for having added their expertise and expert comments from their experience. I would also thank Elagan Company for supporting this event today. Dr. Vishali, who keeps conceptualizing these various interesting topics for our webinars, which again are always very useful and provides us with a lot of useful tips from the vast experience of the experts that we keep getting, like we had from Dr. Neri and Dr. Alessandro. I would also request all the members and all the attendees who have attended today to please provide us with the feedback that how you're finding these sessions and is there any change that you would like to have. Next month's session is going to be on ICG, A and FFA application in uveitis, and I'm sure that's going to be another interesting session that we are going to have. So thank you so much, all of you, for sparing your time, and I think it was a wonderful session that we all had today.
Thank you. Thank you, everyone.
Thank you, everybody.
Thank you.
Great weekend and stay safe.
Thank you so much.
Thank you.
Yeah.
Stay safe and have a
Stay
nice
safe. Bye-bye.
Bye.
Bye.
Bye-bye.
Bye.